In this session, we are going to be looking at the topic dumping syndrome. Hi, I'm Sharon. I'm working as an assistant professor at MMM College of Nursing. The following are the objectives that we'll be addressing in this session. Dumping syndrome, DS, is an often debilitating compilation of gastrointestinal and vasomotor symptoms that present postprandially due to rapid gastric emptying. It was first described in 1913 as a condition that persistently afflicted patients who had undergone gastric surgery. The procedures that were found to result in GS include antrectomy, vagotomy, and pyloroplasty, otherwise known as BNP, and Roux-en-Y gastric bypass. Let's look at the incidence and prevalence. With the discovery of Helicobacter pylori as the primary causative agent of chronic gastritis and the advent of medical treatments for peptic ulcer disease, that is PUD, the frequency of gastric surgery declined. It resulted in decreased prevalence of DS. However, it is still a common complication of gastric surgeries performed for complicated PUD, gastric cancer, and the incidence is once again climbing due to rising rates of gastric bypass surgery. Let's look at the surgical etiology of DS. It is known that the transit of chyme is accelerated from the stomach to the duodenum. It can be due to the following surgeries. First one, esophagectomy. Next, antrectomy occurs in 10% and pylorectomy another 10%. Here, the ability of the gastric remnant to physically hold ingested contents is reduced. The next is pyloroplasty. It also occurs in 10% of the cases. It disrupts the mechanism of the pyloric sphincter. The next is vagotomy. It also occurs in 10% of cases. Here, there is impairment of gastric receptive relaxation to a meal bolus, hence blunting intragastric accommodation and promoting antral filling. The next surgery is Roux-en-Y bypass. This occurs in 75% and gastrojejunostomy. This disrupts the reservoir of the stomach, impairing the stomach's ability to accommodate and hold ingested food. In children, Nissen fundoplication disrupts the reservoir of the stomach, impairing the stomach's ability to accommodate and hold ingested food. Now, let's look at the non-surgical etiology of DS. The first one being diabetes mellitus. In this, gastroparesis and rapid gastric emptying where early Wallerian degeneration and early vagal nerve damage occurs. The next is viral illness, damage to the duodenal mucosa and hence impairment of the duodenal receptors related to osmotic content, fat and protein. This gastric emptying would be accelerated. The next reason is idiopathic. Here, impaired vagal nerve function with loss of gastric accommodation to a meal and hence rapid movement to the antrum and small bowel. Let's look at the pathophysiology of dumping syndrome. Impaired gastric volume capacity or gastroenterostomy can lead to rapid delivery of nutrients into the duodenum. This can be influenced by agents that increase meal viscosity, that is guar gum, pectin and glucomannan. On the other side, by diet as well as acarbose. To conclude, let's look at how it leads to early dumping syndrome and late dumping syndrome. In early dumping syndrome, these agents can end up causing hyperosmolar contents in the duodenum, leading to release of vasoactive agents, release of incretins and release of glucose modulators. That will lead to early dumping syndrome exhibited by vasomotor symptoms, GI symptoms and hyperglycemia. This can also be influenced by somatostatin analogs, that is short-acting analogs or long-acting analogs. Moving to late dumping syndrome, due to diet and acarbose as discussed earlier, there can be rapid absorption of glucose that will lead to hyperinsulinemic response, which again is mediated by somatostatin analogs. That will lead to manifestation as hypoglycemia, which is late dumping syndrome's manifestation. Let's look at the early clinical manifestations of dumping syndrome. In systemic, there can be palpitations, tachycardia, fatigue, need to lie down following meals, flushing or pallor, diaphoresis, that is sweating, lightheadedness, hypotension, headache, and possibly syncope. Abdominal, there can be early satiety, epigastric fullness or pain, vomiting, explosive diarrhea, nausea, cramps, bloating, and boborygmy, which is hyperactive bowel sounds, usually appears 30 minutes after ingestion of food. The late clinical manifestations of dumping syndrome occurs within 1 to 3 hours. Here there can be weakness, perspiration, faintness, shakiness, hunger, decreased concentration, and altered levels of consciousness. Also symptoms related to a reactive hypoglycemia. Let's look at the diagnosis of dumping syndrome. It is based on 6-stat scoring system. Here, all the symptoms are given a particular score. A total score more than 7 is suggestive of dumping syndrome, whereas a score less than 4 suggests other diagnosis. The next test is oral glucose challenge. It is a very useful diagnostic test for dumping syndrome. It is used to elicit symptoms of DS and confirm the diagnosis. Here, the patients are asked to fast for 10 hours overnight and then ingest 50 grams of glucose. Pulse and blood pressure are measured before, during, and after ingestion. The test is positive for DS if the heartbeat increases by 10 beats or more per minute. Blood glucose and hematocrit may also be measured before, during, and after ingestion at 30-minute intervals. A hematocrit increase of 3% in the first 30 minutes suggests early DS. Hypoglycemia 2 to 3 hours after ingestion suggests late DS. Glucose levels can fall to 60 mg per deciliter or less, and symptoms of DS may be reproduced. This is reported to have a sensitivity and specificity as high as 100 and 94% respectively. The next diagnostic method is radionuclide scintigraphy. It is useful in assessing the symptoms attributable to DS. The current standardized method involves consumption of a 250-calorie meal consisting of a scrambled egg substitute that is equivalent to 2 large eggs labeled with 99 technetium sulfur colloid, 2 slices of whole wheat bread, and 120 ml of water. Anterior and posterior images of the stomach are taken immediately after eating and then at 30 minutes and hourly for 4 hours. Gastric retention of gamma counts is performed for each of the images, and the percent of isotope retained in the stomach is thus calculated. This provides a concrete quantification of the magnitude of rapid emptying. Traditionally, rapid gastric emptying has been defined as less than 35% isotope retention at 1 hour, realistically. However, in the absence of other viable explanations for postprandial distress, less than 50% retention at 1 hour may be a tenable explanation for the meal-driven symptoms. A gastric retention of less than 20% at 2 hours may also be used for late DS. Let's address this picture. Here, pink color demonstrates concentrated signal, blue demonstrates disseminated signal, and colors in between on the spectrum represent intermediate signal intensity. Note that at 1 hour, the signal emanating from the stomach is far less intense than at baseline, meaning that most of the gastric contents at baseline have passed out of the stomach. Let's move to the management of dumping syndrome. The first one is the dietary recommendations. Advise patients to have smaller and more frequent meals, about 6 per day, saving liquids for after meals, and also separating dry from wet nutrients by more than 1 hour because liquids accelerate gastric transit. Lying down after meals minimizes the chance of syncope. Decreasing carbohydrate intake and preferentially eating complex carbohydrate, example unsweetened cereals, pasta, potatoes, fresh fruit and vegetables, over simple ones such as candies, cookies, sodas, sports drinks and sweets. Eliminate milk and dairy products as it worsens symptoms. Dietary fiber, which helps to treat hypoglycemia by slowing gastric emptying, can be ingested. Proteins such as meat, fish, chicken and eggs also elicit fewer symptoms and should be increased, as well as fats. Malnutrition may occur, possibly due to fear of eating, hence monitor diet and supplement for adequate nutrition. Bariatric patients require dietary counseling to avoid malnutrition. Here, avoidance of seeds and simple carbohydrates is an essential element of the bariatric diet to avoid symptoms of dumping syndrome. In continuation of the dietary recommendations, increasing the viscosity of the food to decrease the rate of gastric emptying can be achieved with guar gum and pectin. Each is administered as 5-gram doses 3 times a day to start. Both are effective, but patients report poor taste among other side effects. As such, compliance and patient satisfaction are often low. The next is acarbose. It treats postprandial hypoglycemia effectively. Alpha-glycosidase hydrolase inhibitor that interferes with the digestion of polysaccharides to monosaccharides. This helps resolve discomfort from the problematic absorption of carbohydrates in the intestines that characterizes dumping syndrome. In turn, GLP-1, insulin and blood sugar levels stay at normal levels. Because of this particular mechanism, it is useful in treating only late dumping syndrome. Excess flatulence among other irritating side effects are noted. In addition, hypoglycemia is a possible adverse effect of acarbose if carbohydrate absorption is excessively inhibited. Let's look at the pharmacological treatment. Tincture of opium is effective in relieving diarrhea associated with dumping syndrome. Symptomatic treatment for diarrhea includes Imodium. For nausea, meclizine, promethazine and proton pump inhibitors or anti-gas measures may be helpful. Hard candy can be consumed to abort the hypoglycemia of late dumping syndrome. Inadequate digestion of nutrients can cause gas and bloating when they reach colonic bacteria. Therefore, probiotics may be a useful adjunct. However, these treatments do not address the underlying mechanism of dumping syndrome. Anticholinergics slow gastric emptying and are also antispasmodic, thus decreasing abdominal pain related to small bowel motility sequelae after dumping. Example, dicyclomine, hyoscyamine and propantholin. Dosing of dicyclomine can range from 20 to 40 mg 3 times a day given 30 minutes before meals. Diazoxide. It is a potassium channel activator which inhibits the secretion of insulin in beta cells of pancreas in treating late dumping hypoglycemia and can be used when acarbose and lifestyle modifications are insufficient. In continuation, octreotide, a somatostatin analog, alleviates both early and late dumping symptoms through inhibition of hormones such as VIP, that is vasoactive intestinal peptide, serotonin, and insulin. It also delays gastric emptying time and inhibits splanchnic vasodilation. It is administered subcutaneously 5 minutes before each meal with a starting dose of 50 micrograms, although titration from 25 to 100 micrograms may be required. Long-acting release octreotide is a relatively new formulation that is administered intramuscularly for sustained effect. The usual doses are 20 or 40 mg administered intramuscularly once a month. If effects dissipate after 3 weeks or so, subcutaneous supplementation may be required until the next month's dose. Side effects include steatorrhea, gallstone formation, and weight gain. Hence, it is not a first-line treatment for dumping syndrome. However, it is used for patients after other management strategies have not been successful. Let's look at the surgical treatment to dumping syndrome. It is a last resort of treatment. Benefit-risk ratios are best determined by physicians for individual cases. Pyloric reconstruction modifies a pyloroplasty scar by cutting it and creating a longitudinal closure of the incision, recreating the initial alignment of the pyloric musculature. Simple takedown of a gastrojejunostomy if the pyloric channel is confirmed to be open endoscopically. Conversion to a Roux-en-Y gastrojejunostomy may work in some cases, particularly after partial gastrectomy, as Roux limbs can be associated with abnormal motility that may even cause gastric stasis. The next is jejunal interposition, that is, creating an antiperistaltic limb between stomach and duodenum, is rarely used today, as research suggests that an antiperistaltic limb causes excessive gastric retention that will ultimately require a reversal. The following are the references for this particular topic. Thank you for your patient listening.